Well, first of all, thanks, Monse and all the team for the opportunity to be here. As you can see from my face, I'm a PhD researcher. I'm doing my PhD about the implementation of the European Health Data Space, the secondary use of health data applied to rare diseases, because we found out that from the legal and ethical standpoint of view, well, you know, most of you work with health data, of all of you, and you can imagine how difficult it is to manage and to deal with data that is very uncommon and very fragmented, as it happens in rare diseases. And I'm trying to provide a legal governance framework as an output of my PhD thesis, which is going to based on that is an article-based one. I'm working in the Spanish National Research Council. When Monse was talking about the public research infrastructures, well, the Spanish National Research Council is one of the biggest one in Spain, and they are doing a big effort to transform all the data sets that they have in terms of basic research, transnational research, so all the levels of research. They are right now entering in this transformation as potential data holders, as potential data users. And also I'm doing my PhD at the University of Murcia, which has an innovation legal research group. So these are, let's say, my two hats. But what is important today is not me, is what I'm going to discuss. And I would like to offer a presentation with some insights about the regulation and the governance framework that we have in Spain, complying with the instructions provided by the organizers. I try to frame the presentation in a way to focus on the main points that for the project could be interested. And of course, what is more important of this session also is to know about your insights, about your challenges, and how do you see the law and the implementation, because the implementation goes so fast. Secondary use and primary use go hand by hand. The first implementation acts are already provided by the Commission to provide feedback in terms of data sets, in categories of data. So if you haven't done it yet, I really invite you to check the Commission website in the IFS-CSIC, because they already started with a public consultation. So at project level or at individual organizational level, it could be interesting to have some insights. And also you can check the insights from other people that already have provided. And that means that the
Laura, can you see my slides or your slides in my screen? Okay, tell me when I have to jump to the next one, right?
Perfect. No, we can stay in this one for now. I will tell you go to the next slide. So yeah, so before we start with the presentation, as I was mentioning, the race has started, because if we already have public consultation for implementing ads, that means that something is going on, and 2029 is the deadline, not the. So when we talk about deadlines, that means that all the work needs to be done ahead. Saying that, well, as we have seen in all the sessions today, health data is a value to be protected and to be trusted, because we are talking about health data. Health data, as you know, it's a concept which can be very, very abstract. I mean, I'm talking about the health data with the legal lens and with the ethical lens, which are not the same. And this is very important to say. Here we are saying legal and ethical frameworks for use, reuse, and trust. And every time that I have the chance to speak, I always tell to the audience the same. Legal frameworks are not the same as ethical frameworks. They go hand by hand, but depending on the organization, depending on the stakeholder, depending on the actor, depending on the obligations that I have legal obligations and, of course, ethical obligations. If I work for a public institution in terms of research, it's not the same that working in primary care. I will have different ethical dilemmas, different ethical dimensions that I have to tackle. In terms of legal frameworks, I have the legal frameworks, and could potentially, especially in the EU law, can be tackled from different perspectives. So for instance, if I work in pharmaceutical company, I will have the HDS, I will have the clinical trials regulation from a different perspective, rather than if I work in a research ethics committee, for instance, in a hospital. So that's very important, because if we want this system to work, we need to reuse this data and generate trust. Generate trust not only for patients, which is the centerpiece of this regulation. Apart from innovation, the other center to unlock the potential of data sharing, the other piece of the regulation is to allow citizens to access and control their own data and be more aware about the type of treatments and about the type of medicine that they want to have across the European Union health systems. Even though that we have the limitations of Article 168, as my colleague mentioned before, because it's a matter that needs to be further developed in member states. And that goes to the second slide, Monse, which is the governance, the problem and the opportunity, I must say. I'm going to bring the Spanish healthcare system as an example, but there are other countries that have kind of the same approach and the same type of institutions that need to, let's say, build and structure. So in the case of Spain, as Monse was mentioned, is very, very, very decentralized. I'm not talking about only regions, which we have 17. I'm also talking about provinces. I'm talking about different levels of care. Some hospitals are not connected even if they are in the same province. So this means that it's very, very fragmented. And when I'm saying that we have 17 autonomous regions, that means that let's say the governance framework, the legal framework, most of the obligations remain in the autonomous regions, because the main task of the Ministry of Health is to coordinate in order to ensure, of course, the efficiency of the system and everything, but it's a coordination role. And this is the role that actually the Ministry of Health is playing, to have strategies, to have policies in place that need to coordinate and have the agreement of the 17 autonomous regions in order to ensure that this system really works, no? And also it has its own technical infrastructure. So now we have standards, but the standards is one of the key points that as implementers, we will need to provide. So even though that we live in different autonomous regions, we cannot have the different levels of care. So it's a problem. It's something that if you talk with just average citizens, they will claim that. We have citizens across Europe that they don't know where their clinical record is. So then I see the problem, but also I see the opportunity, thanks to the European Health Data Space, to have this kind of minimum harmonization that needs to be done. And also another important point that needs to be tackled here is that if we have a very fragmented, let's say, system, we have silos of health data. So when we want researchers, policymakers, when we want clinicians, when we want patients, when we, for instance, talk about biobanks, which is a very important actor in this implementation of the European Health Data Space, we create these silos because maybe we have data from the same patient in one hospital, in a biobank, and in a clinical trial, or in another research infrastructure. So maybe we have the same data or the same patient in 4 different silos, then maybe they're not able to communicate to each other. So it is not matter only about the borders or about if it's a regional competence or if it's a national competence. It's about a matter of coordination and clear structures. So it doesn't matter if I'm in this region or not. We are going to follow the same protocols and the same structures in order to ensure this cross-border data sharing inside our own country. So we need to act as facilitators. That is can be seen in Spanish, but because it's from the Ministry of Health, this image. But we need the national health system to work together, plus all the feedback from the Data Protection Authority, from the Ministry of Digital Transformation, and of course for the Agency of Evaluation of Drugs and Medical Devices or Medical Products. And of course, all of this coordination needs to be transformed and translated, which is very important because not all the national health systems and national approaches are going to be the same to the European Commission and then to the international organizations. So maybe we can move to the next slide. So let's talk about legal framework plus pilot projects, which we can create this mix between this policy architecture that we are trying to build, you are trying to build within this project. At EU level, I mean, I'm not going to, I mean, it's a lot of regulation, but what is important is what I said when I was introducing myself. Depending on the actor, depending on the task, depending on the position of this, let's say, stakeholder map that you are creating, the regulations will apply, but in different ways. So this is the way that you need to learn the regulation, and of course, have someone that has read them by your side also to interpret it, what the other actors need to do. So of course, the regulation of the European Health Data Space, which Monse also has clarified more or less the timeline. Of course, the GDPR regulation, GDPR and IFS-CSIC, well, there is this huge debate in, at least in legal academia and legal scholars. Well, it's GDPR at the cornerstone, or it's just a supplementary? No. I mean, if you go to the frequently asked questions of the Commission, they have published, I think that it was the 26th of March. If not, we can provide the documents. There is a frequently asked questions done by the Commission, which clarify that GDPR and IFS-CSIC are complementary legal frameworks. And this is also my view, my personal view as researcher. So what does it mean in practice? That all the obligations related to health data from Article 9.2, which means that health data is a special category of data and cannot be processed under certain conditions, it still applies. What does it change with the European Health Data Space? That for concrete situations and for concrete legal basis for data sharing, the European Health Data Space regulation gives more clearance and gives more cases and introduces a governance architecture to process this personal data sharing. And also because for primary use, it is clear that it's personal data, so we need to know about the rights that we have as patients over our personal data, plus in terms of the medical or clinical or care system, how to respond to this and how to make the most valuable approach to tackle the benefits, but also the challenges that this health data could have in practice. Because in primary use, we are dealing with personal data. Whereas in secondary use, we work with pseudonymized, anonymized data. Who is the one that is going to decide if it's anonymized or pseudonymized? The health data access body. We will talk about it later. What does it mean? That there is a huge debate and also a technical point of view needs to be introduced in this conversation about the possibilities of pseudonymization and the value of anonymization. Because for instance, in rare diseases, anonymization maybe is not the best approach, but if we have pseudonymized data, which are the possibilities of identification? This is an open question that maybe you can ask later. And among others, clinical trials regulation is very important. Medical devices regulation, if you are involved in all this process of developing a medical device, especially if this medical device introduced artificial intelligence, be aware about the constant, let's say, updates that we have from the Commission, because everything is changing right now in this, in terms of medical devices regulation. So be aware about the changes, be updated, because this regulation is very important. And also the readiness of medical devices regulation with the UAE Act, depending if you are a deployer or if you are implementing, especially if you are involved in public procurement contracts related to that. I warn you to be aware about this type of frameworks. But there are even more data governance frameworks, data governance act. So this means that depending on your certain case, you really need to know about the obligations and the regulations that could potentially tackle European Health Data Space. It's like a Gruyere cheese, because if you read the regulation, you will notice that a lot of articles refer, first, this will be further developed in a member state regulation. So depending on the country, you will find different national frameworks according to what is open in the regulation. Second, this will be regulated by implementing acts. And third, these provisions will be further developed in Data Governance Act, GDPR, or whatever regulation. This is the way that the European Health Data Space, as it is right now, is working in some aspects of the regulation. So if you are affected by this aspect of the regulation, be careful, be aware, and be updated. In terms of national level, the example from Spain, well, as Monsen has mentioned, there is a tradition of data sharing. There is already a tradition of data sharing, also in terms of legal possibilities, because in the national law, ley orgánica, well, it's an organic law because it's a fundamental right, but I'm going to skip that explanation. The important thing of this law is that introduces a provision that allows for biomedical research and for public interest under the consent of the patient to personal data. And that helped a lot for research and for innovation. But now it's not only the national law what we have the legal basis, and we have more clearance from the regulation of the European Health Data Space. And that allows to have a more harmonized approach for this secondary use of data. Furthermore, we have, as you can see, from 2002 and from 2007, two laws about patient autonomy from one side and how this should be done. So this is basically for primary use, plus biomedical research from 2007. The question here is, should be these national laws updated? Well, right now they're working in a national legal framework in Spain, open for consultation, will be hopefully open for consultation again. So if you are working in Spain or if you want to do this comparative approach, I really encourage you to follow what this policy also movements are going, because it's possible, and some scholars and some people are claiming that these national laws should be updated according to the European Health Data Space regulation. And also pilot projects like this one, or at national level impact data, which is following the 1 million genomes, let's say, approach. They are trying to build big databases of genetic data in order to promote innovation and in order to promote research, especially for rare disease. Another colleague has talked about UNICAS, especially focused on rare diseases. Of course, Health Data EU as the platform. TEDAS2, as Monse was mentioned, is a very important project. And I think that yesterday they opened the third round of public consultation about the guidelines, especially for health data access body, and XShare, which is a project that is working on the clinical records. So I think that all of you are aware of this kind of project. So we can move to the next slide. And where the system stalls. Okay, as you can see, and if you read or take a look of the HCS regulation, some obligations has raised ahead of operational capacity. And this is the main, let's say, claim when you talk with clinicians, researchers, people outside of the legal scope. It's like, okay, Commission or European Union, thanks for this, but please, I mean, we are not capable to transform our system in just 2 years or 3 years. Well, we need here to balance, to see if this is going to be science fiction or if it's going to be realistic. I think that from my personal point of view, I think that it needs to go hand by hand. So we really, as people who work on policy or who work on the technical side, or the ones that need to make decisions, they need to encourage the organizations to increase their capacity to comply with the legal obligations. Because, I mean, of course, there is always time, you know, to claim and to try to postpone some of certain obligations which could be very hard to comply with. But this kind of mindset or operational change needs to be done, because if not, the goal of 2029 seems to be very far, but it's very clear that it's happening in in a short time period. Of course, there are overlaps. As I mentioned, there is a debate in the legal scholars. What is the position of the IFS, GDPR? It goes beyond that. Data Governance Act, everything. So, and then you have all the regional actors unsure which legal basis and safeguards to use for concrete projects. So that's the reality. So as regional actors, which legal basis, if I work in a research ethics committee, or if I'm the manager of a hospital, if I'm the manager of a main researcher of a project, which kind of safeguards can I use for concrete projects? Because I have all these legal frameworks, and in which direction do I need to drive my efforts? Because also this is the strategy. When you need to comply with obligations, you need a strategy, and steps, and methodology, and you really need to know if the project that you want to develop is compliant. So here I see the tensions of all the different legal frameworks, and it's a thing that really need to streamline. And it's not a matter of doing a digital omnibus. It's a matter of really identify which kind of profiles are affected and which kind of obligations we have and how these interrelate to each other. So one possible solution, use cases. But this is just my insight from my research, right? And also draft and soft law HDS implementation guidelines. One example is TEDAS. They are very well done, but they are detailed. I mean, I have read more than 100 pages of one deliverable of TEDAS guidelines. And for instance, for this public consultation, we have 6, and some of them could be more than 55 pages. Okay, for researchers and for people that work on the sector, maybe it's not a problem, maybe you are used to it, but think about the smaller organizations. They have the capacity to interpret it and operationalize them and follow all these guidelines? Yes, no? This is one of the questions that when I read or when I go through all of this, I have. Other points that the system should be tackled, financing and procurement. All of these projects that we mentioned in the previous slides are subject to EU or national project grants. So is there a long-term budget timeline for maintain the systems? I mean, if you talk with people from bioinformatics, they will say, okay, this is very fine. We have a really good system, but this needs to be updated and maintained during the time. So resources are limited. So which kind of a strategy, do we have a long-term perspective about how we are going to maintain all the, let's say, structure that we need to follow the HDS? It's another question that needs to be addressed. Procurement and funding streams. So, I mean, something that it was mentioned before. Well, we prioritize clinical, local IT over across regional interoperability or common services because we focus to offer the best experience to the citizens of our region. So this cross-regional interoperability approach needs to be also think when we go to procurement, that this solution could be applicable to people beyond my region. But again, my resources are limited, so I really need to comply with the minimum conditions to provide a good level of care in my system. So this is also another, let's say, question. And well, data governance, it has been mentioned before, but 2 tools that could be useful, data processing agreements. This is very important for providers, for processors, for everything. It's in the GDPR. It's going to be workable in the HDS and very important. And impact assessment practices, especially if you introduce AI, because it's mandatory, and especially if you process personal data, and it's going to, let's say, help you to anticipate a lot of problems that could potentially happen, especially if you have an audit or an inspection from health data access bodies in case of the HCS or data protection authorities. Well, another 3 points: infrastructure interoperability, trust and citizen engagement, and metrics and accountability. We can move to the next slide. Here I mix 2 slides in one. So it's a comparative lesson and cautionary example. And I'm going to explain why. Well, I think that most of you will know Fin Data and the process that they have beforehand, before the IFS-CSIC was in place, and how from their national law, they're starting to promote legal basis for secondary use of data. So this legal provision that I mentioned from Spanish law, they create something more specific, just an entire law to explain how to process data for research and to give all the legal basis and all the legal clearance. Okay, so this helps a lot now for the IFS, no? So then what's the approach? We are going to centralize, as long as you follow the protocol, all the data requests to Fin Data Authority. We are going to spend the data permit application, and we are going to coordinate the structure for multiple controllers. It doesn't mean how big is your problem, your project, because everything is a one-stop box and a one-stop approach. So, and if there is a problem, the model uses an opt-out approach for secondary uses with clear fees only for preparation and processing and not for the data itself. So it focuses more on the process of obtaining the data permit rather than in the data itself. Okay, according to TEDAS, according to a lot of reports, I mean, it has been seen that it worked because the waiting times, I mean, they drop. Now, instead of 14 months, which it's something that could potentially be familiar, the process in terms of time in your countries, we have 3 to 4 months. So this is perfect. I mean, I'm thinking about clinical trials or other types of research projects. No, the applications have increased, the capacity have increased, and of course the decision subject to appeal. So that means that let's say the effort that they made had increased the stability and the acceptance of the system and also the trust. However, speak with people that have studied the Finland case, because now the risk of this model is that a lot of people from other countries are using this model, but then the results, the outputs go beyond Finland. So that means that I'm using the Finland infrastructure, but from other countries, I'm taking also the output from my benefit. So there are some considerations about if this one-stop model should be more paused because of this implementation of the European Health Data Space and everything, because this model was before. So depending on your approach and which type of actor you are, maybe you will see this as a comparative lesson or as a cautionary example. Next slide. So which priority actions should be recommended? I mean, this is just my point of view. Of course, now in the debate, we can discuss other ways of other points of view, no? But first, if I'm a data holder, I need to check my obligations and which kind of data I have. One thing that is very important in Article 51 of the IFS, some categories of data, for instance, the associated databases for biobanks, are subject to member states' consideration, which means that we will need more clearance in terms of which data sets should be part of minimum categories of data for secondary use and which ones maybe are not. So if you are a data holder, check all the categories of data, check the Annex 1, and then think, okay, which kind of obligations do I have? Just go to Article 60, and then, of course, the standards that you need to use, because maybe you need to update it or maybe not, or maybe the standards that you have are compatible with the current ones. So this is a need to understand which kind of data sets you have as a data holder and be aware about the obligations. If you're a data user, you need to understand, and it has an ethical and a legal dimension too, which kind of legitimate use you have, which uses are prohibited, and which obligations do you have. Because maybe you are asking data for a legitimate use, but then once you obtain the data permit, what you do with the data falls under prohibited uses. And this process of monitoring from the health data access body is something that in all the discussions has been a very strong point. So if you are potentially a data user, you just need to understand what are you going to do with the data and what is the benefit for society and for patients and for everything that you want to achieve in this, let's say, data access application. And of course, you need to be familiar with the data access application, with the process, everything to avoid this timeline that could be very long if you are not aware about the obligations and how you need to do it. Or maybe you will get a rejection and you will invest a lot of time and resources to have your, let's say, secure processes environment, you have your team and everything, and maybe because you don't know how the process of data access application works and how you need to frame it, maybe you won't get the access of the data. So be aware also about it. As I mentioned, use cases with metrics, with deliverables, set a use of cases. The more concrete the cases are, the best benefits and outputs are going to be applicable in the future. TEDAS is let's say, the general framework, but I mean, you really need to structure your project in terms of if I want this data set for treating or for improving this cardiovascular disease, type of data, do I need genetic data, omic data, which type of data, and also be aware about the resources that you have in your region. Because maybe, I mean, it's more interesting for you as a region to apply for a project altogether than just one single organization. Or maybe you don't need to go through the process of asking data in different countries. Maybe you have a strong architecture of biobanks or research center in your own region. So that's or innovators. So that's very important also to know in terms of regional approaches. And another point that I think that Monse is working very hard on it is patients, clinicians, researchers' need of capacity building, awareness of digital health literacy, not only about the European health data space, digital health literacy in general, the difference between medical devices, what happens if I implement AI, do I need AI for everything, the difference between AI for diagnosis, AI for treatments, and of course it needs to be operationalized in all the, let's say, practical words, but speaking the language of your audience, because for legal scholars, it's very hard sometimes to really provide this knowledge on how this law is affected. No, we are very focused on compliance, on obligations, but we really need to understand the user or the person affected or the organization affected by the law, how they need to operate in this new ecosystem and in these new frameworks. And the capacity building for that is essential. And of course, the awareness, especially for patients. And I think that next slide, indicators. Well, as an idea, I was thinking about the idea, the right of opt-out, which is something that also is subject to national law, but is very, very, very needy for secondary use. So is the option that the patients have to say, I don't want to be part of the system. I don't want my data to be anonymized or pseudonymized for secondary use. I mean, it's a challenge for legal, ethical advisors, technical, clinicians, patients, organizations, policymakers. It's really a challenge how to operationalize this in practice. So this could be a type of workshop that should be done with different stakeholders. Which kind of things should be focused? Accessibility, because you cannot create awareness if you don't make the knowledge accessible for citizens or for professionals. One thing that is very important is to involve the people of your organization and think that this is a positive change, because if they don't see the benefits of all of these changes, there will be reluctancy to move forward. And also that this mechanism of opt-out, if you regain trust in the system, you can come again. So how can you do technically without losing the patient or the person that exercised this right to opt out for secondary use? Also mitigate the bias, which kind of patients could potentially go for the opt-out. this is a question that will create, if you answer this question, different answers that are based on bias, because we don't really know. And also how this can be integrated as a technical point of view. And as a whole, let's say, lesson, the benefits and challenges that we will have for the actors involved in secondary use of data, and frame the results for data holders, data users, health data access bodies, to have a common criteria to have data permits, because this is also one of the open questions that we will see once the ETS works in practice. And I think that that's all from my side. I think that I was on time, Monse. So looking forward for your questions and feedback.